couple of people said to me it was confusing.
Hey everyone. If you're trying to pull up the slides for this lecture, they are in Courseworks and they're going to be posted to the OASIS calendar pretty quickly. Just so you know.
All right, guys, we're going to get going. I expect to keep this one brief because we've got diagnosis and screening right after this one, and I want to leave a whole lot of time for questions after that one. This one is pretty straightforward, and you already had, I think, a couple of lectures by Herb Chase about this. He has been putting together a best evidence thread for you guys throughout the entire medical school experience, and we do this, the third year, the fourth year. When you guys are ready to graduate, we do something called Ready for Residency, which is something we're doing right now, and we review all this once more. So let me go to the first slide. So it all begins with your HMP, and that cannot be overemphasized. This is where it actually all starts. If you do a good job at really getting down the pertinent data from the history and you do a very careful physical exam, you will have accomplished already 90% of the work. Some people jump right after hearing something in the history towards trying to get diagnostic tests, and that usually takes you in the wrong direction. I've seen people who are not very experienced in the clinical sense, who know a whole lot of theory, and just get moving in a given direction after obtaining only part of the history and not doing a very comprehensive physical exam, and they get burned that way. So that cannot be overemphasized. You guys will hear a whole lot about the etiology of diseases and clinical manifestations, the epidemiology, and the point is for you guys to make a mental picture of the pretest probability and the potential severity of all different conditions. And the one thing to keep in mind is that oftentimes there are several conditions and they all have competing risks, and they may have possible contraindications in terms of each other in regards to the favorite or preferred treatment for each one of them. So we usually concentrate on simple questions at the beginning just to emphasize how the process is performed for one clinical question, for one possible item. But you guys will encounter in your clinical experience patients who often have 3, 4, 5 different disease processes, each one with a question about severity and best possible treatment. So the differential diagnosis is something that you keep working on, and you essentially prioritize things that are the riskier and most likely to be true, and you start working on those, but you keep the other possibilities in mind at all times. So later on today, you're going to hear about diagnostic tests, how they are interpreted and how they are put together with your pretest probability assessment. And of course, every patient is interested in prognosis. Once you've made a diagnosis, not only you're going to discuss with your patient what the therapies are, what the therapeutic options are, but also the patient wants to know what's in their future. So it's important to know that. And of course, prevention is always fundamental. Many patients come to you because they are seeking treatment, but we keep in mind also the fact that we try to prevent disease down the road, and we try to keep them healthier. And at a population level, this is actually where the money is. Prevention is what improves quality of life for the vast majority of people, and what actually saves society from a whole lot of our cost, human cost, in terms of pain and disease. So finally, whatever you do, whatever you're considered doing, has to be decided upon together by you and your patient. And people over the years have been too paternalistic. You know, we've been making decisions for patients, and oftentimes you still see that playing out in the media when a group of people, group of physicians mostly, get together and come up with guidelines, and they tell the world at what age you should have your first mammography and when you should repeat your mammo depending on what the finding was. Well, those are guidelines, but they actually do not mandate what you must do, and your patient's preferences may actually be completely different from the perspective those experts took. And at the end of the day, what matters is what your patient believes and what he or she wants to have done. This is just a reminder of how to go about finding the evidence in a systematic fashion. This is just one of the acronyms you're going to find thrown around about this, PICO. The first letter is P for patient. You really need to understand who your patient is. This is a little problematic sometimes because for people like me who practice in an environment where most of the people are minority in low socioeconomic strata of society, very few large RCTs and therefore very few meta-analysis actually concentrate on people like my patients. But I keep going back to the same point. It's going to be up to you guys to fill those gaps in terms of research and implementation of research results. So it's important to understand who your patient is, not only in terms of looking for the evidence, but also in terms of advocating for better evidence to be obtained for those patients. I is just for the intervention, and sometimes you pretty much have a pretty good idea of what intervention you're trying to evaluate, and we're going to have an example for that. Then what type of comparison was made, and usually you want to look for the best possible, which is a randomized controlled trial. If you have a few of those, or even better, many of those, and somebody actually went through the trouble of putting together a meta-analysis, that's actually the best possible scenario. But in many instances in my clinical practice, very important decisions are made based upon a single large landmark RCT. So oftentimes that comparison is only being evaluated in one big RCT, and if you're satisfied that the quality of that RCT is good enough, you may counsel your patient to move in that direction. And of course, it's always important to look at the outcome of interest. And this has several nuances. Again, you have to go back to what your patient wants. And for certain investigators, the outcome of interest may have been something different from what your patient is interested in. And the other major item of business is that sometimes investigators will focus on a given non-fatal outcome, and they neglect to look at the effect on all-cause mortality. And when you, as an educated reader, take a look into the data and realize that there might be trends that are worrisome in terms of this intervention being good for something but maybe causing higher mortality, that will be a huge red flag going up for you. Or perhaps the fact that there is no improvement in mortality when there should have been one, and that could be related to the fact that they're not describing all possible outcomes in good enough detail. So there are different ways of finding the evidence. The Cochrane Library is actually an excellent resource. Unfortunately, it's still not that user-friendly, and people are trying to get it better. Actually, one of our fellows here in IT is working on a platform that will incorporate the Cochrane Library with other search engines, so you can use a natural language approach to finding your data, and I'll show you how that works in a minute. But still, if there is a Cochrane review on a given topic, it is 100% likely that that's the best possible evaluation of the available evidence at that point in time. The only caveat is that sometimes there are huge studies coming out, and it takes time for the Cochrane investigators to go back and update their meta-analysis and their conclusions. Medline, of course, is where everybody should go. It used to be based on medical subject heading queries. Thank God it's getting better over time. Still not quite there in terms of user-friendliness as compared to other platforms, and I'll show you an example of that. And then there are many other trusted EBM sites, really depending on your the specialty covering your question. So, for example, if you're interested in the management of atrial fibrillation, of course, the combined American Heart Association, American College of Cardiology guidelines will be your trusted source. And if you're looking at the use of proton pump inhibitors for the treatment of Barrett's esophagus, of course, you're going to go to the American Society of Gastroenterology. So it also really depends on the question you're asking. Appraising the evidence is what we're talking about during this entire course. There are very basic questions you have to answer about each study. And actually, a very, very brief version of those checklists is in the EBM glossary that I gave you guys. It's included in the main document for this course. Just a very few points that you really need to make sure you go through for each type of paper to make sure that it's of good enough quality. Then, of course, when you apply the evidence, you hopefully make a diagnosis and advise your patient in terms of what treatment to go for. Finally, when you evaluate the performance, you really want to know what happens not only to your patient but also at a societal level. And that's a fundamental item of business because at this point in time, we do have a really bad there's really paucity of data at a population level. We have something known as post-marketing surveillance data for drugs approved for clinical use by the FDA, but notification is, at this point in time, believe it or not, voluntary. So you can have a drug that may cause renal failure, for example, in a tiny fraction of patients. Then the drug is approved by the FDA. It's sold into the market, and millions of patients are put on this drug. Believe it or not, at this point in time, it is voluntary for physicians or whoever makes the diagnosis of the complication to report that complication for that drug. And again, advocacy is very important, and hopefully you guys will be part of the effort in the future to change this, because people who are benefiting from selling those drugs should actually be paying for the monitoring. It only makes a whole lot of sense. If you're making billions of dollars and you are one of the most successful industries in the history of the world, you should be able to pay for post-marketing surveillance. So what's next in terms of the EBM model? Well, as I said before, it's up to us to identify what areas still need a whole lot of work. Make sure that people take an ethical approach to research. And you won't believe, I'm in the IRB here, and I review literature about IRBs from other places. You won't believe the things that people are still doing in terms of performing clinical research in underserved populations, vulnerable populations, with payments that are actually pretty much coercive in the developing world, giving patients substandard care just because it's not available to them within their societies, and so forth and so on. This is a fight that has not ended, a fight that needs to keep going on for a very good reason. Okay, it's going to be up to you guys to really understand what a clinical research design implies in terms of protecting the rights of potential participants. And of course, make sure that the talking heads don't take over the conversation and the level of stupidity actually goes down a little bit when we talk about what we know in terms of best treatments and best diagnostic procedures. So being actively engaged is fundamental. Policy is way too important. It's going to be in your hands. So finally, when your patient comes to see you, and especially in a place like this one, they actually put in their entire trust in you. Very few of my patients are actually able to understand the medical literature, even when it's written in lay terms. So they come to me and they say, I trust you, you're my doctor, what should I do? And the perspective I take is, well, if you were my family member, this is the way I will be talking to you. That's my personal take on it. So how to apply the evidence? You guys are going to be working on this a whole lot. You're going to acquire the knowledge, and then you're going to be exposed to the experience. You're going to have trial by fire when you are interns and then you're in residency, and at the end you're going to have all the skills you need. Our emphasis is on how to get the best available evidence, but this is what all comes down to fruition when you make a clinical decision. And of course, we all make mistakes. What matters is to put your best effort, talk to your colleagues, and keep on learning, because that's the only way to keep on getting better. We have this relative hierarchy of the evidence. We keep emphasizing the fact that our meta-analysis, systematic reviews are the best. But as I said before, oftentimes you won't have that benefit. There will be just one or two huge landmark RCTs, and that's going to be the evidence you're going to be working with. Cohort studies are below that. Certain questions, as you already heard, cannot be answered by an RCT because you cannot expose people to things that you know are going to be harmful or could be harmful when you have serious suspicion that that's the case. Case control studies are below that because they have many more biases as compared to cohort studies. And finally, you have case series and case reports. Opinion is at the very bottom. Unfortunately, for many decades, we used to have opinion all the way up here. And to this day, there are still certain professional groups that use opinion or expert opinion in terms of creating guidelines. In most of the clinical societies, that's a thing of the past. And most people, like the American College of Cardiology and the American Heart Association, are using now validated guidelines in terms of qualifying the grade of the evidence before they make recommendations. So you go into a decision with your eyes wide open. This doesn't look very good, but the bottom line is that people are still recommending that you go through the Cochrane Library when you have a question about therapy. If you have a question about diagnosis or prognosis, we're still going first to PubMed. But they are not mutually exclusive, and you guys know that you can open several tabs in Chrome at the same time and do your searches in a parallel manner, so that's not a big deal. The Cochrane collaboration is awesome. They have, this is my last count, but they may have more at this point in time, 53 review groups, and essentially they have people who are clinicians, they have people who are health economists, they have nurses, they have people from who collaborate from different perspectives, and that's very useful. And the other thing is they keep educating colleagues throughout the world. So you're going to have Cochrane review groups that are people who are working in Australia and New Zealand, people who are working all over Europe, people who are working in Brazil and Argentina. There is a group information in Santiago in Chile right now. And anybody who wants to join, you guys, if you want to start learning how to do systematic reviews, you can actually get training. And there are pretty nice scholarships actually to go to Oxford to do a summer session for this. So it's actually an interesting thing to do. The bottom line is that they have really developed the gold standard to review data, and that's a URL for the Cochrane Library. And there are different ways of doing this. You can go by review groups, so if you're interested in cardiology, that's a way you can go through, or you can look for reviews and protocols in a way that's indexed by the title. Now, the most important one, in my view, is new reviews, because that's the one where they just incorporated something important that just got published, and they felt the need to update their recommendations. But it's not that user-friendly. You wish they had a search little window where you can just enter a natural language where you're looking for and get guided through it. But at this point in time, they don't quite have that yet. They have different versions of the same review. And usually the abstract, in my view, is too brief for you to actually get a good understanding of what's going on. The best one is the full article. The standard is actually way too long, and nobody has the time to read that, and you're not going to be doing that if you're on call and you're trying to review something really quickly because you have a patient whose problem just came up. So usually we go for the abstract first, and if that seems to be taking you in the right direction, then you want to pull up the more enhanced version of the article. Now, there are many sources of excellent meta-analysis that are not necessarily in Cochrane, and of course the New England is at the top of the list. So if you ever want to Google for a meta-analysis paper and just make sure whether there has been a recent one in a good journal, you can just enter NEJM right next to meta-analysis and whatever you're looking for, and if there's a recent meta-analysis paper in the New England, it will pop up. The annals is also good. The only problem with the annals is that the format they prefer for meta-analysis is actually quite lengthy, so it's not, beyond the abstract, it's not that user-friendly. BMJ and Lancet are very good in terms of keeping it brief. And they usually have just a very tiny summary where all the data are contained, so you're not losing information by going to the summary, and that's the reason I like the format in BMJ and Lancet. Everybody nowadays is supposed to be following the PRISMA guidelines. This is something that was relatively new a few years ago. Now, any decent journal will mandate that if you're writing up a meta-analysis paper, you must follow the PRISMA guidelines. And so for you guys, if you stick to the trusted sources, you're not likely to encounter a difficulty by reading a meta-analysis that doesn't follow the guidelines. Why do we care about the guidelines? Because the guidelines actually make sure that the data are obtained in the proper manner and that you don't get a biased assessment of the literature. Remember, some people do have vested interest, and they may try to show the evidence in a light that's favorable to whatever they're trying to achieve. So sticking to trusted sources is the way to go. So how do you find RCTs? Let's say there isn't really a huge meta-analysis about the question you're asking. You just want to know whether it's a good RCT or a few good RCTs about your question. Again, you can go through Medline, you can go to the Cochrane Registry, you can go to clinicaltrials.gov. Actually, this is fantastic if you're doing your own meta-analysis, because every clinical trial that has been conducted in this country for the last 10 years had to be registered beforehand at clinicaltrials.gov. That was a wonderful thing. This is actually a fantastic change that took place a few years ago, because in the past, people were doing clinical trials without telling anybody and without opening up their methods section to the world. And the result of that was that we had a lot of obscurity. We had people conducting clinical trials and not publishing the results at the end, or not being clear about the statistical methods they were planning to use beforehand, and then they didn't get the results they wanted, and they went in a fishing expedition, and then they found something, and that's what they reported. So that's thankfully a thing of the past, thanks to clinicaltrials.gov, because every study has to pre-register. The problem with clinicaltrials.gov is that it doesn't quite have updated links to the actual paper. So somebody may say, yes, I performed a study asking this question, and yes, I finished up my study, but then there is no link, no URL link to the actual PDF for their paper. So from that point of view, it's not that, that useful. The Brits have something very, very good, which is database of abstracts of reviews. So essentially, they have a group of people from different leading universities who get together and review papers, and they put together very well-formatted abstracts, and that's their database. And they use that to disseminate findings to their primary care providers, what they call the general practitioners. And of course, whenever the AHRQ looks into something, they do a fantastic job. The problem is that they haven't looked at many clinical important questions over the last few years. There are certain sources that usually you have to pay for, but some of them are actually free if you just register, like BMJ updates. Those are fantastic. And in BMJ updates, you're going to have reviews not only of articles that appear in BMJ, but also articles in other journals that they think are important for practitioners. The National Guidelines Clearinghouse is just for guidelines, so if it's not formally labeled as a guideline, you're not going to find it there. And then the NICE keeps this NHS evidence database together for the UK. So this is PubMed, and we're going to start here because everybody wants you guys to be familiar with this. You can see there are many different ways to go about this. I actually don't have either the time or the patience to go through an advanced search in the way they want you to do. Like, for example, I very rarely now use a mesh database anymore. I used to do that decades ago, but I have stopped doing that. If I know what journal it appeared in, then I will go through the journal's database. That's actually a very useful resource. But what I usually do is I just enter natural language in here, and I click on search or go, and then I limit by RCTs if it's a clinical trial that I'm looking for. This is actually a pretty good database. I don't quite know what their final goals happen to be. They are a non-for-profit at this point in time. I didn't see much in terms of advertising from private companies in there, but it's actually pretty good in terms of looking for things that are spelled out in natural language queries. And you can get pretty similar results to what you get when you're using Google. So let me just go into specific case. So this is actually a real patient of mine. When she came to me, she was 72. She's African American. She's a retired school teacher, and she had very long-lasting hypertension, and it got complicated by CHF. Her ejection fraction was preserved. It was 55%. And you guys may have heard about this already. The big characterization we make in terms of CHF is, do you have preserved ejection fraction or not? And we have a whole lot of information for people with low depressed ejection fraction, decreased ejection fraction. The vast majority of RCTs are about those patients, and we have much less information in terms of what's good for people with preserved ejection fraction. We used to call these people patients with diastolic abnormalities or diastolic dysfunction heart failure. We moved away from that term because there's much more to it than just diastolic abnormalities, and there are other mechanisms at play. But anyway, she's on a pretty good regimen of lisinopril. She's on a diuretic, and she takes atorvastatin with excellent response in her lipid levels. So she had been admitted to Milstein due to CHF exacerbation. She came out, comes to my office within a week for a post-discharge evaluation, and she's doing all right. I don't find any CHF signs at the exam. Her EKG is perfectly fine. She's in normal sinus rhythm, and she's got the same LVH in the EKG she had before. And as usual, she's extremely compliant with medications and diet. And she wants to know, what can she do to stay away from the hospital? She hated being admitted. She had to go through the ED, hours of waiting in a very uncomfortable stretcher. Then you get moved to Milstein. She hated the entire experience. And she wants to know, what else can I do to stay away from the hospital? So this is the way I looked at it. She's an African-American patient with preserved ejection fraction heart failure. And, you know, I went into this with the benefit of knowing something about this, and I knew that there had been a recent paper about spironolactone, which is an aldosterone antagonist. It's diuretic that preserves potassium. And I had reviewed very quickly a paper, and that was like in the back of my mind. But it was sometime prior to her visit, so I didn't quite remember the specifics of the paper. I just walked away with the gestalt that there wasn't much in terms of improvement, but maybe there was some benefit. So this is, of course, something that has to do with death because we're dealing with CHF. So the first thing you want to do whenever you implement a new treatment, whenever you add a new drug to the treatment of CHF, you want to make sure that mortality is reduced or at least not increased. And then this is her question. Can I reduce my risk to be admitted because of CHF? And obviously, you always want to know, is there a price to pay in terms of other side effects? So adverse effects, the unintended consequences of what we do is always in your mind. So this is a Cochrane library, and this is how you can go. You can either go by topic and look for CHF. You can go A to Z looking for spironolactone, but I had other people waiting in my waiting room, so I didn't have the time to go through all this. So if I had the time, you can go to heart failure, find diuretics, and click on that link, but it was extremely annoying. So what did I do? I went to the library, and I entered in natural language, I entered spironolactone, and then I enter heart failure, and then I made that query, made the query for those terms in the title, the abstract, and the keywords for trials. So you can see that's all, and that's trials, and this is what you get. I'm not sure if you guys entered that in real time right now with the Cochrane library, you'll get the exact same result because things do change in databases as time goes on. But I found this paper by Bertram Pitt, which is the paper I was interested in. But, you know, what other ways could I have gotten to the same place? Well, I could have done a PubMed advanced search, entering in all fields I'm looking for CHF, and then in all fields I'm looking for spironolactone, and when I get that, I filter by clinical trial. And then in second place, I'm getting the same RCT, the TopCat RCT. So it's not quite in the first place, it's in the third place. If I enter natural language under Google and I go to Scholar, this is what I get. It's in second place. So obviously, this one is just reviewing the TopCat study, because as you can read here in this very brief sentence, they are actually reviewing the TopCat study. So it's not the first one, it's the second one, the one I was looking for. So TRIP actually also gave it to me in second place, not in the first. By the way, this is a subgroup analysis from the study, but I didn't want to go into that. I wanted to have the results of the main RCT. So this is the abstract from the original TopCat paper, and this is essentially what I was looking for. So I learned very quickly that they had a very fair number of people with symptomatic heart failure and good ejection fraction, and they were randomized to either spironolactone or placebo. Now, the dosage here is a bit tricky because they went from 15 to 45, and actually the lowest dose we've got here for our clinical practice is 25. So the 15 is not applicable to us, but you do what you can with the data you've got. The mean follow-up time is actually good. It's 3.3 years. And the primary outcome was actually a composite. They had death from cardiovascular causes, cardiac arrest that was actually aborted, people were resuscitated, or they had hospitalization for the management of heart failure. So why do you think they will have a composite outcome like this one? So what's the alternative? If you wanted to have just one single outcome, what's the first outcome you'll pick? Of course. So that's the alternative. You can say my primary outcome is to look at death, and then my secondary outcomes will be prevention of hospitalizations and resuscitated cardiac arrests. Why will they take this approach of putting them together into a composite outcome? What do you think? 1 minus beta? They're trying to have power. So in essence, they didn't expect to have a huge reduction in mortality, and they said, yeah, we'll see some reduction in mortality, we'll see some people staying away from the hospital, and hopefully we'll see that resuscitation rates got better, and therefore we can show that overall things get better when you move in that direction, or people don't need to be resuscitated because they don't go into cardiac arrest. So if you put together all the possible good outcomes, you get a composite outcome. Now, you as a reader, whenever you see that, you want to know at the end of the day what happened with each individual component of that composite outcome, okay? Because sometimes people will throw in things that are not of equal importance, of equal value. Or you may have a situation in which you are preventing admissions to the hospital, but your mortality is higher, and people are not getting admitted because they're dead. So never underestimate the importance of looking at the effect on mortality separately from taking a look at all the other possible outcomes, okay? So what happened here? You know, over 3.3 years, the primary outcome took place in about 18.6% of people in the spironolactone group, as compared to 20.4% of people in the placebo group. So the hazard ratio is actually good. What's going on here with the confidence interval? Speak up. Perfect. And that actually coincides with a p-value that's not less than 0.05. So there is a trend that doesn't reach statistical significance for our usual threshold of p less than 0.05. Remember, the hazard ratio is similar to the relative risk that you can estimate in a crude manner, but it's actually more powerful. It has greater statistical power to identify effects. So it's good that there seems to be a trend towards a reduction, but the upper 95% confidence limit is beyond 1, and therefore we're not really certain that that's not a spurious chance finding. So what did I say before? Well, whenever you look at a composite outcome, you also want to break it into its components. When you do that, and you look at hospitalization for heart failure, you can see that it's 12% in the placebo group. I'm sorry, spironolactone is 12%, and it's 14.2% in the placebo group. That hazard ratio now is 0.83, and the upper confidence limit does not cross 1. So now our p-value is less than 0.05. We have statistical confidence that this is a true finding, and this is actually suggesting that you're reducing the risk of hospitalizations, of admissions due to CHF by how much? I think I heard the right answer. 17%, just like with the relative risk. You do 1 minus that and you get the relative risk reduction. Okay? What is important to keep in mind is that that happens over a mean follow-up of 3.3 years. So they could not reduce total deaths or hospitalizations for any reason, meaning people got admitted for other reasons. And importantly, when you look at the adverse effects, treatment with spironolactone was associated with increased serum creatinine levels and a doubling of the rate of hyperkalemia. So that's important. Of course, it reduces the risk of hypokalemia because it makes you retain the potassium. However, with frequent monitoring, there was no significant difference in terms of serum creatinine level going up to a level that's really dangerous or having people needing dialysis. So that's important, because if you see a drop in glomerular filtration rate, you really want to make sure you're not causing serious damage to the kidneys. So overall, it did not, the treatment with spironolactone was not beneficial for the primary outcome. So this will be, you know, at societal level, most people will discuss the TOPCAT study as a negative study because they could not reject the null hypothesis for their main question. However, for the question our patient is asking, maybe there is some information in there. So does the study question match the question you had for your patient? I think the answer is yes. Was the study design appropriate? Yes. Now, recruited patients. And this is the trick. We don't know, essentially, how well spironolactone works for people with substantial African ancestry. We do know that if you're using ACE inhibitors and angiotensin receptor blockers, for example, for the treatment of heart failure, you do not get the same efficacy estimate, and that's why people have performed other studies, for example, the use of hydralazine and isosorbide in patients with CHF and low ejection fraction, and that worked beautifully. There was a very, very impressive reduction in mortality in that study. It was the AHEP study. But in this case, 89% of the participants just have European ancestry. So this may be limited information, and until we have more studies in people from different ethnic groups, we will know. The remarkable thing also is that the two largest ethnic groups in the world have very little in terms of evidence, in terms of medicine. I'm talking about people from mainland China and the Indian subcontinent. Together, they actually constitute the bulk of the global population, and there's very little information in terms of whether they do benefit from the exact same interventions of people with European ancestry. So we keep pushing for what our patients need here, and most of our patients here in Northern Manhattan, when they are minority patients, they are either African American or they are Hispanics, mostly Caribbean ancestry or Mexican Americans. But when you look at the global perspective, we have very little data when it comes to Chinese populations and people from the Indian subcontinent. So was it a randomized study? Yes. You're going to see this word quoted a whole lot. It's concealed. That means the randomization process was made in a completely blinded fashion. It's a machine, it's a remote computer doing it, and there's no interfering with it. And we call that concealed allocation of the randomization. It comes up in step 2 and 3 all the time, and in the boards of internal medicine. It just means that randomization is performed in a completely blinded manner. Was everybody blinded to the intervention? Yes. And were people treated equally regardless of treatment assignment? Yes. So did they have good follow-up? Yes, they had fantastic follow-up. And how large was the treatment effect? Again, the relative risk reduction for admission because of CHF was 17%. How important is it to look at the confidence intervals? Let me just go back. So what is this telling you when you have an upper confidence limit of 0.99 for the hazard ratio? Somebody, anybody? It's pretty close to 1, right? So what's up with that? Is it going to make you much less enthusiastic about the finding? The fact that it's very close to the null hypothesis line? But how much less enthusiastic are you going to be? In other words, is this result of 0.99 as likely to represent the true population value as the hazard ratio of 0.83? Yes? Somebody else? Do I have a no? So, in essence, you have to remember that the most likely finding is the point estimate we give you, the 0.83, and that's the reason we pick it. But then we try to look at how confident we are around that point estimate, and for large studies and for what we call asymptotically normal distributions. I don't want to make it too complicated, but things that tend to have a distribution similar to a bell curve after certain transformations with large data sets, it sort of looks like that, with the peak of the probability distribution belonging to the point estimate, and then the tails going down in probability towards the 95% confidence limits. Okay? So actually, even though you're saying I am 95% confident that my true population estimate is within this range of values, the greatest information is actually for 0.83, and much more so than for 0.99. So yes, we lose a little bit of enthusiasm when that upper confidence limit is very close to 1, and we take that with caution. And you may want to say, well, I'm not impressed with this. If there were another study that showed slightly different result, maybe I would move in this towards the null, and maybe there is no benefit at all. If I do an analysis after the second paper, and maybe I'm just giving people hyperkalemia and some drop in GFR. So yeah, it's perfectly okay to be cautious. And if you guys want to say, I don't really like that upper confidence limit being so close to 1, that's perfectly fine. Just keep in mind that still the most likely result is the point estimate. So I didn't find any threats to validity in this particular study, and I thought they actually revealed the sources of support and conflict of interest were properly addressed. So how do you apply the evidence? Again, are the patients in that study similar to my patient? Yeah, but not quite, because I need more studies in people with African ancestry. And how much of the study effect can you expect? Well, it's the 0.87 in terms of hazard ratio for CHF readmissions. But I need to keep in mind the fact that it goes all the way up to 0.99. Is it realistic? Well, I use spironolactone a whole lot, so it is realistic. It's not too expensive. It's available in any pharmacy. And does the environment reflect my current practice? Absolutely. It's pretty much what I do with my CHF patients. Do I have alternatives? Well, not at that point in time. And did I consider all the relevant outcomes, and were those outcomes in the paper? Yes. Are they relevant to my patient? Again, yes. And does the intervention meet my patient's values and preferences? And here I enter yes, because I had already talked to my patient, and essentially she couldn't emphasize enough how much she hated being admitted and how much she wanted to stay away from the hospital, and the fact that she would rather die than being in and out of the hospital. She just hated that. So in essence, she was pretty much predisposing me to trying things, and also she is the perfectly compliant patient. She comes to every appointment, she takes all her medications, she follows a diet, she gets her tests right in time so we can review them together when she comes to the office. So with her being like a perfect patient, I didn't have any qualms about putting her on yet another medication, because I knew I could monitor her potassium. So what I explained to her is that the data suggested that there might be a reduction in terms of the risk of dying, but we weren't sure that if the trend was there, it had to be confirmed by larger studies or by the performance of an independent study with similar results, and that we could reduce the number of CHF-related admissions. So this is the number needed to treat. now magnitude of 50 over 3.3 years. How good is that in terms of population level? In other words, if you are consulting for, you're a public health consultant in Brazil, and they ask you, should we buy spironolactone to make it available to all our patients? We have a huge population of aging patients with preserved ejection fraction heart failure, and they just keep getting admitted to the hospital. Is this something that we should start manufacturing? Footnote, Brazil does manufacture their own drugs for their formulary, so they do a wonderful job at making them available to people without financial means. There's 100% access because they manufacture the drugs. So is this something you will be recommending? Or will you say, well, come on, you're going to have to bring people back and check the potassium quite often. You're going to have to make sure there's no renal failure. I'm not quite sure. And the upper confidence limit, again, is 0.99. What do you guys think? I bring that up because there's no one single answer. And people may have different answers with the same evidence. And until you keep on developing new clinical trials and you keep performing them and reporting them, we're not going to be entirely sure. So, sometimes people get frustrated because they say, well, I wanted to walk away from the talk with, the perfect answer to my question. Well, there is no such thing. And as a matter of fact, I've learned over many years, I graduated from medical school many years ago in 1984. I've learned over the years that things that I thought were perfectly fine were not. And I've learned over the years that you shouldn't be the first one prescribing a new drug until it actually undergoes post-marketing surveillance. The things we thought were perfectly fine, like the use of Vioxx and Celebrex for arthritic pain, we thought it was perfectly fine to prescribe them because we believed the reports from the RCTs funded by the manufacturers, and then we found out that they were not reporting the bulk of clinical events, and actually both Celebrex and Vioxx caused a higher risk of myocardial infarction and cardiovascular death. And I had put a fair number of my own patients on those drugs because I just happened to believe what was being reported without data from post-marketing surveillance. So when you look at something like this, it's a very difficult decision to make, and I usually make it with my patient, talking about all the possible risks and the benefits, and I try to make it clear that we're not stuck with that decision. In other words, come back. We'll recheck your blood test. If there is a trend for your GFR to be going down or your potassium is going up too much and you really don't want to change your diet to reduce the potassium intake, we'll just stop it. I mean, you're not really stuck with that clinical decision forever. Okay? It's a flexible process. And the same thing happens when I prescribe a new drug. For example, when my diabetic patients have very poorly controlled A1C, and they come to me and they say, well, I really want to try this new Byetta drug, and I hear in the news that it's fantastic. Well, what I do is I sit down and I try to spell out for them what the potential benefits and what the potential risks are, and I tell them, if you would like to go for this new treatment, these are the things we need to monitor you for, and this is how quickly you need to come back so we can stay in touch. Don't just take this prescription and come back in 6 months or a year, and then I learned that you got admitted with a massive renal failure. So in this case, we had a long conversation, and she really wanted to take the spironolactone, so I gave it to her, and to this day she's doing just fine, and she hadn't been admitted again. So it worked out, but there's no guarantee that it's going to happen every single time. So what else should you do? Again, important, extremely important. Very little evidence to support the use of this drug in African American patients. There need to be more studies. And the perfect example of that is the AHEP study, which combined, as I said before, hydralazine and isosorbide for people with low ejection fraction heart failure, and the benefit in mortality was just remarkable. So this is something that got implemented into clinical practice right away. If the research is important, oftentimes you need to ask the NIH to pay for it. Oftentimes, pharmaceutical companies will find that they are selling the drug just fine, thank you very much, and they don't need to do another RCT. So we need to get together and put pressure on the NIH to actually pay for the studies that are needed for our patients. And, until such research is conducted and reported, you have to work with whatever is available to you. Finally, you need to continue to evaluate the outcomes in the clinical setting. And remember, post-marketing surveillance is voluntary. So it's up to clinicians, it's up to you guys to report things, bad things that happen to your patients, even if there's the slightest suspicion that it might be related to a new treatment. So again, this is just a list of useful resources. I quite like BMJ Clinical Evidence. This is, if you're a medical student, you can access this for free. And the Oxford Center for EBM also has pretty good resources for EBM. All right, that's it. Any questions? All right. So Dr. Moran should be here for diagnosis and screening tests shortly. It really depends. Like in this case, you know, I have a background in cardiology, so I had the advantage of reading the literature, but sometimes it's something that is completely outside of my comfort zone. So I will tell the patient, give me your cell phone, I'll get back to you tomorrow morning, and then, you know, I go upstairs to my other office and I sit at the computer and I try to figure it out. Yeah. But, you know, the thing is, Google is becoming the way to go. I don't want to overemphasize that in my recorded lecture because some people still are very old-fashioned, but I just did a meta-analysis and I did a query using all different possible sources, and when I went to Google, I found 3 articles that nobody else gave me. So I actually included them in my meta-analysis. They keep on, you know, this natural language thing keeps getting better because you keep benefiting from people who did queries before you. Hey. No. Actually, I've got a graphic. If you, yeah. Not quite.
I mean, my understanding was that the normal distribution determines the width of the combination. And then
right. So
there are 2 issues. One issue is we're not talking about the probability of the result being the true one. That's the most complicated conversation because it takes into consideration the prior project and then you incorporate the result. But if you're just talking about the concept of the result likelihood, I can actually, if you email me, I can email you a graphic that I created. So essentially, you can normalize all this. You can do, for example, log relative risk, and you can plot, and you are going to find something like this.
So let me have access here. In essence, you normalize it by using the log of relative risk, for example, and what you end up having is you can have something that goes from 0.99 to 0.128. So many people get stuck on this being below 1, right? And they say, and this is the point estimate, okay? 1 to 3, for example, right. 1, 1, 3. No, 1, 1, 3. I don't remember my example. So this is your point estimate, and this will lower confidence limit. And this is for something bad. So many people look at this and say, I'm not sure that it's really bad for you. But when you look at the probability distribution of the results, you end up having something like all this being compatible with being 1.10 or greater than that, and only a tiny fraction over here being below 1, this being not showing a significant reduction. So this would be the logarithm of the relative risk of 1. And this is the probability distribution for a result that's below 1 in here.
So I guess what I'm talking about the actual probability of the event. Is that what I'm mixing up? Because that is true for the confidence interval, right?
Right. No. But what we're talking about is the probability that your value reflects the true efficacy or the true treatment effect.
Okay.
So based on your data, how likely it is that those boundaries are capturing the true population value. And actually it peaks around, that's why we use the number.
And then
Which number?
the probability distribution is not like this. It's not 0.99 here and 1.28 here. It's not like this. In other words, 1.13 is not at the same level in terms of probability density as 0.99. It actually drops towards the extremes.
Huh.
The probability density.
Okay. I have to look into it a little more, I guess. But I'll send you the email so I can see.
All
that.
right. Okay.
Actually, a question on the case that you were discussing.
Yeah.
So it seems like you went into the different search engines
Yeah.
with an idea or an inclination that sort of think it would be helpful.
Right.
And I'm just wondering, for people without like the insight,
Yeah.
like how useful they are
Right.
in just providing an organized list of all potential therapies that would be effective.
No.
Not limiting yourself to like one certain thing.
It's a great question, but that's essentially why we go to medical school and residency, because it's the only way that you put together that basic kind of knowledge that will give you a platform to start doing the other questions.
Right.
No, your question is absolutely pertinent, but you know, the idea is, the question is, can an intelligent person who's not a medically trained person go into a data research and actually find out the evidence in a way that's clearly explained from beginning to end? The answer is not really. You know, because there are so many pieces of knowledge that we've acquired over the years. Some of them are evidence-based, some of them are legacy items, things that we've been doing forever, and that we don't even dare to test anymore because they work. But you're absolutely correct.
It seems like that would be a way of organizing.
Well,
data,
that's what
though.
people try to do when they create things like WebMD
Right.
and Watson, the interface they have for people who are asking medical questions and things like that.
Right.
Absolutely, that's the idea.
Right.
But we're not there yet. Yeah.
Thank
All
you.
right. Sure. Probability distribution. I got you a question about confidence in the representation of the probability of the population. And people usually say that I feel confidence in the equal reaction to the population is the other one is the loss of probability distribution. Right. So what I did is I log transformed relative risk and then I plotted the probability density. And actually I'm working on that to train people not to overemphasize the confidence interval. Because this is what I did all the time. This is from the Optimal study that showed that mortality was 13% greater on losartan as compared to Captopril. The lower confidence limit is 0.99. And many residents say, oh, there's no difference. Your best estimate is 13% greater. It peaks at that point. And actually, the cumulative probability beyond that is like 76% of the entire probability distribution.
Okay. That's great. I've never seen that graphic.
Well, it's something I've been working on, and I wanted to. I'm testing the residents. I'm testing how they react to different forms. So I'm giving some of them this, and some of them just the confidence interval, and asking them, what do you think? Eventually, I'll get enough data points.
Cognitive bias.
Yeah.
You read Stephen actually.
Right.
I haven't made my way through because it's just too hard to read sometimes. But it's really fascinating.
Yeah. He thinks so.
Yes.
Wait. Oh, you may want to thing. Oh, you okay. It's not quite good yet. I think, yeah. I think you have to unmute it.
The Bayesian mathematician and statistician. I like it as a thought process.
Yeah, we went briefly. Yeah, and then we were getting because I'm going to Argentina in October. I'll show you the pictures if you have it. What city are you in?
Yeah, I just had one of my longtime patients. I didn't realize he was from Colombia. We were talking about it today. He's from Cartagena. So I told him the story of my college friend whose family's from Italy. They left. This was the 1990s.
Right.
Yeah.
All right. Is that working? All right, guys. We're going to get going. So, Dr. Moran was actually sitting there, not in this room, right? Many, many years ago.
No, this room.
This room.
Yeah.
Right. So he did his residency in internal medicine here. He got his MPH here. We actually met when he was working on his MPH. He went to UCSF to do a Gen Med fellowship, then came back. He's a cardiovascular epidemiologist, and he's an expert in modeling. And his papers have been published all over, including the New England. And his latest work was in the cost effectiveness of the guidelines to treat hypertension and the effects they have in terms of the cost and the efficacy. So it's great to have Dr. Moran to give this talk to you guys.
All right. Thank you, everybody, for coming today. I think this is a really exciting lecture about something that's going to be familiar for you throughout your careers, the use of diagnostic and screening tests. No matter what specialty you go into, you're going to be ordering tests, and hopefully you're going to think about why you're ordering the tests and what the test result is going to give to you. Now, I think I have the pointer. All right. So I have nothing to disclose. So the objectives for today's talk, we're going to talk about you're going to order these diagnostic and screening tests. How do the tests help you make decisions, and how can you judge if a test is useful to you or not? And we're also going to review not only diagnostic but screening tests and demonstrate ways to evaluate the value of the tests. Okay, so most of this lecture I'm going to be talking about diagnostic tests, and at the very end we'll talk a bit about screening tests. So we're just going to start with a case. And we have a case of a woman who's got a swollen knee, a right knee, as you can tell. And does this patient have septic arthritis of her knee? Septic arthritis is an infection inside the joint space. Okay, so here's our case. This is a 48-year-old woman. Her chief complaint is, my knee is red, swollen, and painful. You take I'm putting you in the emergency department for this case. And as you're taking your history, you find out that this has been going on for 2 days. Patient has no history of joint disease when you ask her about it, no surgery, no trauma, no risk factors for infection. And then you move on after taking your history to doing your physical examination. And on exam, you find she has no fever. The skin over the knee is warm. It's red and tender. There's a palpable effusion. You can feel the excess synovial fluid. And so you want to start by finding out, the question is this septic arthritis? Is there an infection here? So you want to know, well, for all patients who come to the emergency department with a red, swollen knee, how many of them have septic arthritis? And on average, the answer is about 18%, based on this prior JAMA paper that you found. Okay, so are you going to treat your patient with antibiotics? That's the clinical question here. You can see there's a simple treat, no treat decision here. Here are 3 options I'm going to give to you, and I'll let you tell me what you think of the 3 options. The first option is, well, we'll just wait and see, because if this is a septic arthritis, if this is an infected joint, eventually it's going to declare itself. And we'll have more data tomorrow, more information. We might as well gather more information before going ahead and treating this patient. Option 2 is that we know that 18 out of 100, 18% of patients are going to have septic arthritis. Why don't we just go ahead and treat her with antibiotics? It will treat the infection if she has it, and if there's no infection, well, with no harm done. Just the medication. And then the third option, of course, is I'm not sure, can I order a test first? So in terms of the obvious answer is 3, but in terms of number 1 and 2, does someone want to volunteer why those are not good choices? Why do we need to do this diagnostic test? Breed resistance. She might have a reaction. She might have a toxic reaction to the antibiotic, and then you've done harm. You're supposed to first do no harm, remember? Okay. And what about option 1?
The arthritis declaring itself could be more harmful than currently is.
Yeah, this is actually potentially a very critical infection. It has to be, you have to act on it quickly. The person, she may lose, her joint may get destroyed by the bacteria and by the inflammatory response, and she'd lose the use of that leg. So it really, we need to know sooner than that. That's why we need a test. Okay. So before moving on, reminder that we're starting with this probability of 18% that she has septic arthritis at the beginning. You're going to see later this is called our pre-test probability. That's what we know now. And now we want to know more because we're not ready to make a decision yet. So in terms of these decisions, some of them are easy and some of them are difficult. The difficult questions are the ones that require the diagnostic test to help you decide. So diagnostic tests aid decision-making by revising your disease probability, revising your prior probability into a new probability. So if the patient has a disease that's of low morbidity and mortality, and it's a relatively rare disease, we may not need the information from a test. We could just go ahead and not treat that person. Okay? But if it has a disease of high morbidity and mortality, and there's a high probability the person has a disease, you really don't need that diagnostic test. You know enough already, just go ahead and treat the patient. But we're really in this third category. There's uncertainty. There's moderate morbidity and mortality, and we need a test to help improve our knowledge so we can make a good decision. So the question is, which test do you want to order? Wisely, you're in the emergency department. You're a very smart medical student. You decide, well, why not go to someone who actually has been working here a long time, knows what she's doing? I'm going to ask the nurse. So the nurse says, you should do an arthrocentesis. That's the test you want to do. So you go ahead and collect your supplies, and you draw out the fluid from the knee. And the result is that you find a white blood cell count of 128,000, and your culture is pending. And so the same paper that you found before tells you that for a patient that has a white blood cell count greater than 25,000, that's a good cutoff for increasing the probability that someone has a septic arthritis. So your patient has, we call in this case, if we draw the line there, a positive test. So let's think about how that helps you make your decision. Okay, so I think you had your lecture already on observational studies, and you've seen a 2x2 table. Okay, so this is going to build on your knowledge of 2x2 tables. In this case, we're setting up our 2x2 table with disease positive, negative on the top, which is maybe familiar for what you did before. But this time on the rows, we're going to put test positive and test negative instead of exposure positive and negative that you saw before. Okay, so going down the columns, if I add up these columns, I'll have all people with disease in this first column and all people without disease in the second column. And people with the disease and a positive test result are true positives. With the disease, negative tests, it's a false negative, false positive, no disease, positive test. And negative test without disease is a true negative. So just absorb this, because these are, the way we set up this table, you're going to see in your homework, helps you calculate the kind of test characteristics that you're interested in. So some definitions. Prevalence is all disease positive over the total population sample. Sensitivity is true positives over all people with the disease. And as you think about these things, these concepts are very simple, but they can become very confusing. You get them mixed up in your head. A good way, a point of reference to anchor yourself is always look at the denominator. That's the key. So sensitivity, the denominator, is all people with the disease. So as you think things through and tell your friends about what is sensitivity, think about who's in that denominator. For specificity, it's true negatives divided by the denominator of all people without the disease. Positive predictive value is different because now the denominator is all people with a positive test, and it's the true positives in the numerator. And negative predictive value is true negatives over all who test negative. Now I'm going to illustrate this with this disorder that's red gingerman syndrome. And the red, if it's a gingerbread man that's red, it's a diseased gingerbread man. Okay, so sensitivity is the probability of a positive test in people with the disease. So our denominator is all the red gingerbread men. And the numerator is all of them that have a positive test. So if you calculate that, we have a test that's 95% sensitive here. And this shows the true positives over all the gingerbread men who have the disease. And now we're going to talk about specificity. So now the dark red gingerbread men are the ones without red gingerbread man disease, or reddish brown. I don't know what the color is exactly. But you can see that even in these subjects who do not have the disease, some of them are going to have a positive test. It's not a perfect test. So these 5 test positive. And so if we calculate the probability of a negative test in subjects without the disease, it's 15, is these 15 with a negative test over the 20 who don't have the disease, and it's 75% sensitivity. Now we're going to look at, okay, this is just showing you again specificity, isolating the population without disease. Positive predictive value for this same population that we're looking at, it's the true positives divided by all people with a positive test. In this case, you count up the true positives are the red gingerbread men over a denominator of all positive tests, and that's 79%. And negative predictive value is 94%. It's the true probability of not having disease in those who test negative. Okay, so it's all the people without a positive test. Okay. So now getting back to our case and our patient. So we have this patient with what we know now about the probability of septic arthritis. We know this patient has a swollen tender joint. The history in exam, non-contributory. The synovial fluid, WBC, 128,000. And so we need to take this test characteristics that we learned from the JAMA paper, a sensitivity of 77%, a specificity of 73%, and use that information to calculate a new probability of disease and see if that changes gives us enough information to make a decision to treat or not. Okay, so when you're setting up, you're going to, in your next homework for not this week but for next week, is going to be about this topic, diagnostic tests. And you're going to have a problem to work through. And in setting up the problem for either the homework or for the exam that you take, it's good to start with a round big number for your total population, in this case 100,000, and you're going to start filling in the blanks. So out of these 100,000 people, we remember that our average prevalence is 18%. We're going to start with that. That's our prior knowledge, our prior probability. And we're going to take that and calculate 18% of 100,000, and now we have filled in one part of our table, the 18,000 people with, all the people with the disease. And using our sensitivity, remember the denominator is all people with the disease, we calculate using 0.77 the number of people who, with the disease who test positive and the number who test negative. So we've filled in half our table, our 2x2 table, and now we just simply subtract off the 18,000 to get the population of people without the disease, and we go through some calculations using specificity to fill in these final boxes in your 2x2 table. So this group here is the numerator of, it's the number of people without the disease who have a negative test. And once you find that out with specificity, you can just subtract off to find that last box. Okay? So that's using your 2x2 table. And now we're going to add up across the margins, because what we really want to know in this case is we have a positive test result, right? And the question is, that's pertinent to making this decision is really the positive predictive value that we heard about before. So given the positive test result, what is her probability of having septic arthritis? Okay. So now we want to know the positive predictive value. Of all people with positive tests, what proportion of those have a true positive? So now I take the true positives over all positives, and I calculate the positive predictive value of 38.5%. Does everybody follow that? Okay. Okay, so now we're going back to our decision tree. We started, our prior knowledge told us that this patient had 18% probability of septic arthritis. Our test result was a positive test, and it told us that her new probability with a positive test is 38.5%. So we revised up our probability from 18% to 38.5%. So what do you guys think? Is it now time to treat this patient? Did that test result help you? 18%, 38, 39%? Anyone have any reaction to that? Does it give you a lot of confidence about ordering those antibiotics? Not particularly. So in this case, it wasn't that helpful, but we're going to see some different instances where the test result can really move the needle a lot more. Okay, so doctor, I forgot to tell you. So the patient, you circle back to give your patient her test results. She said, I forgot something. I forgot to tell you that I do have a history of rheumatoid arthritis. I've had arthritis for years, but just slipped my mind. So, so we find out that among patients with rheumatoid arthritis who come to the emergency department with warm, swollen knees, 38% of those patients have a septic arthritis. So they have your pretest, your prior probability is much higher than what we had before. So how does that change the interpretation of your test result? So starting with this prevalence of 38%, we have to recalculate all our numbers. We start with our 100,000 again, but now because it's prior of 38%, we now have 38,000 people in the disease-positive column. So if we recalculate, you can see you shifted a lot more people over to this disease-positive column, and that really changes by shifting from this cell to this cell, from cell B to cell A. We really have increased the positive predictive value. It's now our test has told us that our patient has a probability of septic arthritis, 64%. Now, what do you think about treating with antibiotics now? Okay, we have more confidence. Feel better about it. It seems like a more reasonable decision to make having had that test result. So if your patient is higher risk to begin with, that changes the meaning of the test result. Okay. So the lesson here that you just saw numerically is that positive predictive value, negative predictive value change as a function of the prevalence of the disease as well as the sensitivity and specificity. And I showed you that really that happens because you're shifting a lot more people to the leftward column of people who have the disease, and that increases the positive predictive value. But remember that the sensitivity and specificity, those test characteristics are stable because they're the ratio of positive and negatives within the patients who have or haven't the disease. So if you change the prevalence, that doesn't change that relationship. You might have to mull that over, but you'll see if you just look at your 2x2 table. Okay. So, yes?
Positive predictive value supplied on the labeling of the diagnostic test itself? I mean, you wouldn't want to run this equation each time you had to figure this out, right?
You'll see when... I'll repeat the question. Okay. The question is, where do you get this information about? There are hundreds of diagnostic tests out there. How do you know what are the test characteristics for my test? There are resources that have them. You're kind of thinking, well, yes, I could probably find it if I spend some time looking up, but I'm working in the hospital. I'm working the wards. I need to make my decisions quickly. How do I know? And I think the answer is, there are two answers to that question. One is, you will accumulate knowledge about the test. You're going to see in the homework, there's a very commonly used test for predicting probability of pulmonary embolism. That's the whole source of your homework number 2. Just about every clinician who's practicing knows that the D-dimer, the test we're talking about, is a highly sensitive test with low specificity. And they know that older patients are much more likely to have a positive D-dimer test. Almost every clinician knows that. It takes time to kind of build that. You don't have to look it up. You kind of, not everyone's going to remember it's 99.5% sensitivity, but you're making those flash decisions about how to interpret this lab result, and that will be internalized. So that's one answer. But there are a lot of resources. You'll see at the end of homework number 2 that there are resources for kind of calculating these numbers. Based on some of the major tests. The information is well known, and there are online calculators and ways of doing this quickly without a lot of difficult work on your part. So does that answer your question? Yeah, okay. All right, so I'm going to shift. I'm going to show you the same thing we just looked at, but we like to present this in the framework of a Bayes theorem. And I think the reason is just because it shows you kind of the concept behind what we're talking about when we talk about pre-test and post-test probability. But also, I think we teach it this way because some people respond to the mathematical formula much more than they do to the 2x2 table. I think it just, whatever your thinking style is, you can choose whichever way you prefer to do this. So I'm going to show you the same information in a different way. So here we're introducing this idea of Bayes' theorem. Basically, everything I've been peppering my conversation with today, where you take a prior and you revise your prior to end up with a posterior odds or probability. Okay, so that's in terms of mathematically, what we want to do is take our pretest odds and we can multiply it by something called the likelihood ratio and end up with a post-test odds. That's how our diagnostic test revised the prior probability into the posterior probability. So the likelihood ratio, you're going to see what that is in a moment, but we have to work with odds before we go to probability. So you may have seen, did you learn about odds ratios? And, yeah, so, and odds is simply probability over 1 minus probability. And likelihood ratio is it's a nice tool because it combines two aspects of the test, the characteristics of your test, the sensitivity and the specificity. And so likelihood ratio positive is the sensitivity divided by 1 minus specificity. Likelihood ratio negative is sort of the mirror image of that, 1 minus sensitivity over specificity. So this is the likelihood ratio for a positive versus a negative test. You're going to see, I'm going to just walk you through how this works. But basically, likelihood ratio positive, it's the probability with over without, basically probability of a positive test in a person with the disease divided by the probability of a positive test with a person without the disease. It's not the positive predictive value. It's a characteristic of the test and not dependent on the prevalence of disease. So it kind of goes back to what I said earlier. Okay, so this is how to make your calculation end up with your post-test probability, like we already did, using Bayes' theorem. So first we want to find out what is our prior based on our current knowledge. That's the prevalence. So the pretest odds, we take prevalence divided by 1 minus prevalence, or probability divided by 1 minus probability, and that's 0.38 divided by 1 minus 3.38, and that's our prior is 0.61. That's our pretest odds is 0.61. Once we have the pretest odds, we can now use our likelihood ratio. And likelihood ratio, what is that? It's sensitivity divided by 1 minus specificity, so it's 0.77 divided by 1 minus 0.73, and that's 2.85. That's our likelihood ratio. And now we take our pretest odds, multiply by likelihood ratio, positive, and we get 1.75 post-test odds. And now finally, we need to convert our post-test odds back into a probability. And so that's 1.75 divided by 1 plus 1.75. And our post-test probability is 64%. So if you remember back, this is exactly what we had for our patient with rheumatoid arthritis when we calculated her post-test probability. So same result as a 2-by-2 table. It's just using the Bayes' theorem formula. Okay. So if you remember how we defined our positive test, we just said any white blood cell count in the synovial fluid above 28,000, all of those are positive. Do you think that someone with a white blood cell count of 27,000 is different from the patient with a white blood cell count of 28,000 is different from a white blood cell count of 800,000? Yes. Does someone want to explain why you think that? It's no pressure, but.
Well, I mean, there's inherently going to be some sort of error in the test. I don't know specifically what it is for white blood cell counts. But if you're at 26,000, the confidence interval on that would overlap with 25,000, as opposed to if you're at 127, where the probability would say you're most definitely.
Yeah, exactly. And so you're saying, there's a margin of error that you're worried about. And there's also just that, a lot of these tests, there's a sort of a dose-response relationship that some test results are more positive than others. You'll probably hear clinicians say that at some point. So by having a single cutoff, we're really losing a lot of valuable information that our test could give us. And you'll see this again when you do you work through the homework for next week's small group. So how can we get some more information out of our test? Well, let's break down some of the spectrum of WBC counts in the synovial fluid. So if we take patients who are in the range right near our cutoff, their likelihood ratio is 0.8. So, in fact, the 28,000 cutoff, that was just an average of people over 28,000. Actually, people are at exactly at 28,000, the test isn't really that useful. But the people who have greater than 100,000 white blood cells in their synovial fluid, if you have a result that high, its actually likelihood ratio is 29. So that really revises your prior probability a lot. So we really would lose a lot by just having that one plus or minus cutoff. And just to show you this concept graphically, I'm going to show you, there are two panels for the next set of slides. This is your white blood cell count in the synovial fluid on the x-axis here. On the y-axis is simply the number of patients who have that result. And the first distribution, the bell curve on the left, is people without the disease, without septic arthritis. And on the right, you have your patients who do have septic arthritis. And you can see, importantly, that there's this area where they really overlap, and a lot of them have the same test result, whether they have or haven't got the disease. But the people who have a very extreme test result, it's very certain that they have the disease. Likewise, people who have extremely low white blood cell count. Okay? So let's look at some different thresholds for defining a positive test and where that lines up in these distributions. So if we choose a white blood cell count, I think this is about 50,000, you can see that setting the threshold at 50,000, that we capture a lot of people who have septic arthritis, but we've labeled a few people without septic arthritis with a positive test. And what that means down here in the lower panel is increasing sensitivity, increasing the probability you'll identify someone who truly has a disease, and on the bottom is 1 minus specificity. So as you go to the right on the x-axis, you increase the number of false positives. So by setting this relatively high white blood cell count threshold, I've identified a lot of people with the disease without gaining a lot of false positives of people without the disease. If I lower my threshold now to, I don't know what this is, 20,000 or so, now I have captured a lot more people who have the disease, but I've paid a price because now I've labeled a lot of people without the disease as having septic arthritis at that lower threshold. And you can see what happens with this curve where the amount I'm gaining in sensitivity is decaying over time as I pick up more and more of these false positives. And my specificity is decreasing. And now if I set a threshold of any white blood cell count in the synovial fluid, you can see what happens. So I feel great. I've identified every single patient with septic arthritis. The problem is, if I use this as my tool for deciding who to treat with antibiotics, now I'm treating the whole world with antibiotics, anyone with a red swollen knee. So really moving along this part of the curve, I have gained very little in terms of sensitivity, but I've sacrificed a lot in my specificity. The probability of having a negative test in people without the disease, that's my specificity, has become extremely low. So that doesn't seem like a good option. So this is plotting what you just saw. At the white blood cell count of 100,000, we really gained a lot of sensitivity without much sacrifice in specificity. Still pretty good at 50,000. We've ramped up the sensitivity and without a great loss of specificity. But as we we get to a lower and lower threshold, we really lose the value of the test. So this is showing a fairly good test where there's some overlap between the distribution of the test results in the patients without and with the disease. This is a perfect test. Anyone who tests positive with this test, they've got the disease. Anyone who tests negative, if we draw our threshold right here, we can discriminate perfectly between disease and non-disease. And this is a terrible test where if we draw the line anywhere, we're going to have pretty bad specificity. We're going to pull in a lot of people without the disease and maybe subject them to harm. So if we plot these three tests that I just showed you, the perfect test, it goes to 100% sensitivity at whatever threshold you want to draw between the two population distributions. And the perfectly useless test, in other words, this test in the blue dotted line, you would do just as well to flip a coin than to order that test. You might as well just go into a back room and flip a coin whether you're going to treat with antibiotics, because this test is no better than flipping a coin. But most tests are somewhere in between those extremes, and you can find a threshold, depending on what you're interested in, where there's a good balance between identifying the people with the disease, using your sensitivity, and excluding the people without the disease, your specificity. And what we just saw a drawing of is also called an ROC curve, receiver operating curve. And it's basically can be interpreted as a signal to noise ratio. The dashed blue diagonal line in the ROC curve, it's the likelihood ratio of 1. Positive tests equally likely for people with and without the disease. And the area under the curve of your ROC curve you can use that to calculate the C statistic. And most tests end up between these two extremes, like I said, of the worthless test, it has a C statistic of 0.5, flipping a coin, and a perfect test, where it's perfectly accurate every time. So most tests in the real world lie somewhere between those extremes. All right. Any questions about the diagnostic test? That's the hard part. Now we're going to just cruise through the fun of screening tests. Any questions about diagnostic testing? Okay. All right. So we're going to shift gears. We're going to talk about screening tests. So some definitions here. A diagnosis. Diagnosis is made in patients who have signs or symptoms of disease. Okay. Is everybody clear about that? Okay. Screening is something we do in people without symptoms. Otherwise, it's not symptoms. And I always think about this when I'm in clinic. Just hit the microphone. When I'm in my clinic. So I think recently I had a patient who she had weight loss. She was a smoker for a long time. She had weight loss. She was coughing, short of breath. And I thought, maybe I want to order a CAT scan of her chest to see what's going on. I think there's enough going on here that points toward the possibility this patient has a lung cancer or other malignancy. Is that a screening test? Am I screening her for lung cancer? No, because she is in this upper category. She has symptoms that are consistent with having lung cancer. It is a diagnostic test. Okay. We're going to hear about lung cancer screening in patients without symptoms. That's what a screening test is. Okay. So what are attributes of a screenable disease? It has to be a disease that's important, significant morbidity, that it matters to patients. It's something they want to avoid. It's not just a label, but actually something that could either kill them or give them significant symptoms in the future. You want it to be a prevalent disease, that it's worth investing in. It's a problem in society. And you want to have a disease that has a latent asymptomatic phase, a detectable preclinical period. Really fast-moving diseases, probably not worth having a screening test for. And you want there to be a treatment available. So you don't want to give someone the label of having a disease or they're going to develop symptoms in the future if there's nothing to be done about it. What have you done for that patient? You've just given them a lot of anxiety, and whatever time they had left before developing symptoms, you've really soured that time by giving them a label and a diagnosis, because you're not going to be able to help them anyway. And early treatment has to be better than late treatment, because otherwise you may as well wait, just like I said before. So to show this graphically, we have some timelines here. The panel on top is showing, not showing screening, it's just showing a natural history of disease. For a relatively slow-moving disease, there's a biological onset, and there's an incubation period, and then the patient, after a while, manifests symptoms and truly has a disease. And then there's this clinical phase where they have signs or symptoms of disease. During some point during that, hopefully they get a diagnosis, and based on the diagnosis, they can receive a therapy. And after that, they'll have some outcome from their disease. Okay. So what does screening change about what you saw in panel B? You have a biological onset of disease, but now here in this preclinical phase, you're doing your screening test, and you're detecting the disease, or the disease that will develop early before symptoms would have developed in the natural history. Okay? So more attributes of a good screening test: it should be accurate. So we talked about those characteristics earlier: sensitive, specific, reliable, cheap, and acceptable to patients. Usually it should be non-invasive, not so hard to undergo. But there are possible, I alluded to this before, there can be adverse consequences of screening people. Remember, you're screening people who are asymptomatic, currently healthy people, and you have the risk of misdiagnosis. If your test is not perfectly accurate, you could give them a false positive. Diagnosis without effective therapy. Again, we said that why tell someone that they have a disease if you can't treat it? And there can be cost of the test without benefit, and there can be labeling. And this year I added a couple of slides just based on a paper that recently came out. I thought that was interesting regarding screening. So I mentioned before in the patient I mentioned with the symptoms and signs of lung cancer, there's a recommendation lately where there's a low-dose CT scan is being promoted as a screening test for lung cancer. Now, it's being used wisely only in patients who've had significant smoking history, who are, I believe, age 55 and above. So it's not screening the whole population. It's a relatively high-risk group. But one thing that came up in the trial where they showed that this was a good screening tool, it had little effect on smoking cessation in the people who were screened. Why do you think that could be? What is going through the screening test? What might people think? What might be some unintended consequences of screening people?
You might say, well, I don't have lung cancer, so
Yeah, that's exactly right. So let's see what happened. Actually, they did a study in the Veterans Administration where they're rolling out this screening program, and they did these in-depth interviews with 37 current smokers who were offered CT screening. And here are some of the things that came up in these interviews. So some patients saw screening as an external agent. They felt like it was something they could do to to be healthier, and much easier than quitting smoking, which is very difficult to do. Okay, so something they could do. And they also, some of them thought it's sort of like a treatment. It offers protection against developing cancer. Like you said, if you have that negative test, that means you're not going to get cancer in the future. And it also emphasizes lung cancer as the only harm of smoking. We know that smoking can raise the risk of multiple diseases, but by focusing on lung cancer, that can make some patients perceive that as the only possible risk of smoking. And having a negative test can help consolidate an error in thinking that some smokers have, that it's not going to be me. So because I have a negative test, it's someone else who's going to have a positive test and develop lung cancer. So it's not that we shouldn't do this test, but you should just be aware you're the physician who's ordering this test. It's clear that you have a lot of work to do to educate your patients about what the result of the test means, whether it's positive or negative. Okay, so some concepts that are important about screening tests. Lead time bias and length bias can lead to overestimation of the benefits of screening. So lead time bias. If we compare the survival time of someone, let's say, here's someone without screening in panel A. They have the biological onset of their disease, and then they started to have symptoms, and they were diagnosed and treated. Okay, this is an old book, 1997, 2000. So this is their survival time, from the moment they were diagnosed to the moment they died of that illness. Let's take, in panel B, someone who goes through a screening program. The biological onset of disease was the same, but this person was detected by the screening program. Aha, you have lung cancer now in 1994, and then they die in the same year, but what's counted as their survival time is much longer. That's the lead time. The lead time is this interval between when they would have been diagnosed anyway and the extra time that the screening test added on. Okay? So the problem is that you can't compare this survival with that survival. Does everyone see that? That the time living with symptoms of disease is actually exactly the same. So the way to deal, this shows, the addressing lead time bias. So the survival time is different, but it's biased by that extra lead time, and the way to get rid of that is to have a randomized trial of your screening tests so that you're following all people for the same amount of time, and you can see if you set that start observation time at the same moment that the person who died in the screening program and the person who died without the screening program, that in fact they had the same survival time. Just depends on when you start counting and observing this person. Okay, length bias. So the other important screening bias is length bias. It arises because some tumors or diseases are very slow growing, very slow to progress, and others are very rapid and rapidly fatal. So the slow growers stay in the screening interval window longer than the fast growers, and we'll show a picture of that. So if we look at length bias, here is a fast progressor, someone who had a very rapidly developing disease. And here is a very slow progressor. Okay, and you can see if you have this screening that happens at a set interval yearly or every 5 years, every 10 years, that if you're doing that every 10-year screening, this rapid progressor who developed the disease and died within a year, they are not going to be counted as screened or followed. So you're going to capture a lot more of these slow-growing cancers. So if you're comparing people in the screened versus the not screened, there's a bias there because you're picking up all these, these kind of less fatal and slow-growing diseases. So that makes the screening program look better. And this can also be addressed by randomization, where you're following every person in that cohort, screened and unscreened, for the same amount of time. Okay, so that is the end, and we have some time for questions, if you guys have any questions. Okay, so just before you clap, before you erupt into incredible loud applause, no, you'll really get a chance to work through these problems in your homework, and if you have any specific questions, I'm happy to stay for a few minutes and answer questions. Thank you.
So there is a great app for phones, MedCalc, and it has an evidence-based medicine module. It's free, so you can download that and verify your estimates for 2x2 tables. It's pretty cool. Yes. You remove view and 2 slides.
Oh, theorem. Thank you. That's my spell check.
Thank you.
Well, I really like that. I guess you had that same with the Perrier PE paper, but it's really great for illustrating all that.
Right.
And it has the, you can look at the different test results. Yeah, sure.
Can you always assume that whatever test you're using applies to the specific population?
Right. Well, you can, and actually a good illustration of this is if you look in the paper that you're going to have, the pulmonary embolism paper, you'll see that in the older patients, that the test performs totally differently. So that's an example. And it could be that yes, you can have the different. You should calculate things differently based on whether they have rheumatoid arthritis, whether they're old, young, male, or female. So yes, that's happening.
But it has, you have two different aspects. One is the predisposition is different depending on whether you're government or private or not. That's one thing. You may have additional information in regards to sensitivity and specificity in different populations, but if you don't have that, you only have an overall estimate of sensitivity and specificity in most patients. That's the one you're going to use.
Right. Yeah.
Okay.
Right. Yeah. That's.
Our emphasis is on always considering predisposition because that's a common mistake. People tend to overemphasize things to a diagnostic and run with it, and oftentimes they forget.
Is that this lecture? Is that today's?
And that
The vision
also
one.
tells you whether you need a
The
diagnostic.
vision one, Dr.
If
Gary.
you have somebody with very low predisposition, maybe you don't need to.
I have a question about sensitivity and specificity. So sensitivity is the one where it's the number of true or the test positive, or the total number of people with the disease.
Yes.
That's correct. Okay. And
By the way, that happens. It is, like I said, it's very simple, but we have to kind of state it very carefully.
So then why it's, they like say, oh, sensitivity is, if you have a high sensitivity, you rule out the diagnosis. And then like a high specificity, you rule in the diagnosis.
We don't quite say that, but that's why he didn't mention that, because the idea is you want to put
Right, you
together
didn't
your
mention
pretest
it, but-
probability. No, and there's a good reason why he didn't mention that. Because if you have a very high pretest probability, if you are pretty certain that somebody has a condition, you can have a very sensitive test come back negative, and you won't rule out anything because you started with a very high pretest probability to begin with. So one of the things we emphasize is always put them together. Never forget the pretest probability. And that's why we don't use those rules because they oversimplify. Now, if you start off with a lower or intermediate low pretest probability and you have a negative test and it's highly sensitive, then you can rule out.
Then you rule
So
out.
you
the
can
diagnosis.
only rule out.
So
when
you rule out
start-
if they test negative.
If they test negative and if they have a pretest probability that's low or intermediate, not if it's high.
But I do like to, when I think about, like you say, like the test is highly sensitive and I'm ruling out, I try to think of my denominator always, and I think people who have this illness, almost none of them have a negative test result. So a negative test result
Means that they definitely don't
it's
have it.
very informative. Whereas the other case of the highly specific test,
So you have to look at the denominator,
almost
not
no
at the,
one
not
who
at the
doesn't have the
numerator.
disease has a positive test. So it's very yes. So that's I always think
Yeah, I
denominator.
was get, okay, it's getting that confused. Thank you.
Sure. Just a quick question. I don't know if I'm thinking about this right, but in terms of Bayesian bias, is that basically a function of treatment not being effective?
No, you caught them before they were symptomatic. People who declare themselves by having
Right.
symptoms already have a larger lung cancer and they're going to survive less.
Right.
People who are still asymptomatic may have a tiny cancer, you diagnose it at the time of screening, and then you follow them up and they appear to live longer because you caught them early.
Right. But it also suggests that if you catch them earlier and you start treating them earlier, but they die at the same time.
No, but that would be a true treatment effect. If you catch them early and you operate on them, and that's why they survive
Yeah, this
more,
is
that's a
like
true treatment
if it
effect.
doesn't really. We're trying to illustrate examples where it didn't really make a difference, but we're not saying that you could have a really good treatment that could prolong survival, but the survival it's going in the other in that timeline you're actually extending further instead of adding on the back end. Does that make sense?
Yeah.
So how do you detect that? So, well, let's say you have a good screening test for lung cancer, and you randomize people to get in screening test and not get it. And you're going to capture a whole lot of people, who are slowly progressing, and you're going to catch them early. If there's a good treatment and you decrease mortality from lung cancer later on because you treated them, what you're going to have is at the end of the day, the group randomized to screening are going to have a higher prevalence of lung cancer, but a much lower mortality.
Yeah.
So the prevalence of cancer is going to be greater because you diagnose it,
Because
early,
you- yeah.
but they're going to live much more.
Because of the treatment.
Right.
Okay. That makes sense. Okay.
All right.
Yep. Thank you.
Very good. That's a great question. It's a shame you didn't ask them to the open.
So are the lecture systems in Ericsson are the videos on?
The slides, yeah, they put the slides in your books. I forgot to mention that if you want to show something on screen, it's actually better to use the mouse. So people who are watching it can see the cursor because they can't see the laser pointer. So when they record, it's the voice and